moderating today's discussion. I'm honored because this is such a star-studded group, and we're going to speak authentically on engaging communities to maximize relevance and impact. So joining us today are Dr. Alison Brown from NIH, Denise Holston from Louisiana State University, and Kelli Wilson Begay at Maven Collective Consulting. Next slide. I'm currently on leave from the University of Georgia, so I know firsthand the importance of NCORE and presentations like today that help give researchers, practitioners, federal staff, advocates, and parents food for thought. So currently I'm on an interagency agreement between the University of Georgia and USDA and serving as the Director of Nutrition Security and Health Equity. Next slide. As we focus on children, families, and communities throughout this two-day workshop, I want to emphasize that one of my most important jobs is being a mother of 3 little girls who are pictured here now, and they are ages 10, 8, and 6. And at my house, we love cooking and growing veggies in our garden and singing songs like the broccoli song together, which you can see in my TED Talk, which is why this picture is here. And now lately, I've been doing it at some meetings as well. So next slide. At UGA, my research, teaching, and community engagement focuses on using innovative approaches for early childhood obesity prevention. So you see my dear former research assistant here who is currently at CDC and about to pursue her PhD in nutrition, dressed up in this wonderful carrot suit because we use the arts to engage young children and families about learning about nutrition as well as our early care and education providers. And a great deal of my work and my research really focused on promoting USDA's programs such as SNAP-Ed and CACFP. And as this group knows well, there are critical public health impacts that are a result of these wonderful programs. And right now we have such an incredible opportunity to make them even better. So much of my research and the research of others has shown that CACFP improves the quality of foods and beverages for young children while they are in care. And you can see here this logo. I can tell you so many stories about being the co-lead for the UGA SNAP-Ed project, Healthy Childcare Georgia, where we aim to improve our teachers' self-efficacy to build healthy habits among children. And we engage them in learning about things like My Plate and trying new fruits and vegetables. And it's just been amazing to hear parents call and ask why their kids are asking for more kiwi, and they're running out to buy apples and broccoli and the things that their children are able to taste. And our teachers are modeling eating healthy vegetables, and one even wrote a grant to have a water fountain installed on the playground. So now in my role at USDA, I have the privilege of promoting these programs and our other tremendous assets to help everyone in our country thrive. Next slide. We are very proud of our accomplishments in advancing food and nutrition security and implementing the National Strategy on Hunger, Nutrition, and Health that was released the day before the White House conference. And we are working again to make My Plate a household name. Throughout all of our work, the way that we scaffold our work in nutrition security, one of the major core components is prioritizing equity every step of the way. But we know we can do more and we can do better together. So we're so excited to be here, and we're so excited to hear from our esteemed panelists about doing community engaged work in a way that is authentic. So I'm going to turn it over to Dr. Alison Brown. Thank you so much for joining us today.
Thank you, Caree, for that wonderful introduction. Really grateful to be here and speak on behalf of my colleagues at NIH on the COMPASS program. So as Caree mentioned, my name is Alison Brown, and I serve as one of the COMPASS workgroup coordinators, as well as a program director at the NHLBI. So I have no disclosures to share. And firstly, I would like to acknowledge our COMPASS co-chairs who provide strategic direction for the COMPASS program. So we have Dr. Janine Clayton. She serves as the Associate Director for Women's Research and Health. Dr. Joshua Gordon, the Director of the National Institute of Mental Health. Dr. Eliseo Perez Sable, the Director of the National Institute in Minority Health and Health Disparities. And lastly, Dr. Shannon Zink, the Director of the National Institute of Nursing Research. Next slide, please. So the COMPASS program is certainly an NIH-wide effort. As you can see on this slide, we acknowledge our work group members who represent various institutes, centers, and offices across NIH, as well as the many Common Fund program staff that help with the operations of the COMPASS program. Next slide. So what is COMPAS? So COMPAS stands for Community Partnerships to Advance Science for Society. As you know, in the federal government, we love our acronyms. It's supported by the NIH Common Fund, and its focus is to support community-led structural interventions that leverage multi-sectoral partnerships with the ultimate goal of intervening on social determinants of health and advancing health equity and reducing health disparities. Next slide. So what is the Common Fund? I like to think of the Common Fund as like the venture capitalist of NIH. It's funded by the Office of the Director and managed in partnership with NIH institutes and centers across our agency. And it supports a set of NIH-wide efforts and programs with the goal to foster innovative and transformative impact to benefit the broader biomedical and behavioral communities. And similar to other Common Fund programs that you might be aware of, like the Nutrition for Precision Health powered by the All of Us program, as well as Motor PAC, Common Fund programs are meant to accelerate emerging science, remove roadblocks, enhance the scientific workforce, and support high-risk, high-reward science. Next slide. So in short, the Common Fund is meant to move the NIH mission forward as well as faster by supporting bold scientific programs that are important to the missions of many NIH institutes and centers and offices. It supports biomedical and behavioral advances that otherwise would not be possible without this initial significant strategic investment. Next slide. So the overall goals of COMPAS are twofold. So one, to catalyze, deploy, and evaluate community-led health equity structural interventions that leverage partnerships across multiple sectors to reduce health disparities. And then secondly, to develop a new health equity research model for community-led multi-sectoral structural intervention research that will serve as a model not only across NIH and other federal agencies, but also other funding agencies. And again, the goal of COMPAS is to be carried out in partnership with multiple sectors. And we talked a lot about this yesterday. And these sectors include community organizations, other federal agencies, businesses, and local and state governments, and specifically through what we call within COMPAS the local and national HERAs, and HERAs is short for Health Equity Research Assemblies. I'll talk more about that later. Next slide. So as part of the strategic planning for COMPAS, we held a total of 8 listening sessions in October and November of 2021, and it included representatives from a variety of different stakeholder groups. So academic institutions, including minority serving institutions, tribal communities and organizations, foundations, think tanks, advocacy groups, professional societies, nonprofit and community-based and faith-based organizations. We also planned these in partnerships with community organizations who also co-led these sessions. So we were excited to have over 2,100 registrants for these listening sessions and over 500 participants. And we had some key themes that were pervasive throughout the different conversations. So one was the importance of community ownership and community-led research, forging in relationships and building trust, particularly for those communities that have been historically disenfranchised, the importance of community capacity building, the need for more innovative public and private partnerships, the importance of some more support for navigating the NIH enterprise, also the creation of interventions across multiple sectors, and data and evidence that are needed for structural interventions. Next slide. So a key innovation of COMPAS is its focus on structural interventions, and I know Chris Economos talked a little bit about that yesterday. And in Arlene Brown's 2019 article, she defined structural interventions as an attempt to change the social, physical, economic, or political environments that may shape or constrain health behaviors and outcomes, altering the larger social context by which health disparities emerge and persist. So the goal of these more upstream interventions is to address conditions where people are born, grow, learn, work, play, live, and age, impacting a variety of different areas. So human and social services, commerce, healthcare, economic and urban development, transportation, education, housing, and justice. Next slide, please. So a key aspect to the innovation of COMPAS is that it's community-led research where the funded organizations, particularly for the community-led structural interventions, are actually community-based organizations. And we know from the research that community-engaged approaches are key research strategies to address health disparities and advance health equity, particularly for communities that have often been left out of the research paradigm. So community-led research is really an innovation that really switches the paradigm and changes the process by which research has traditionally been conducted, requiring a transformation in the process and practices that govern research engagement. Community-led research also serves as a unique approach that aligns with NIH's goal to enhance acceptability and sustainability of effective interventions, and overall compasses innovation in the approach to community-led research will hopefully advance health equity and sustain positive health impact for all communities. Next slide. So to achieve this goal, there are three initiatives that comprise of COMPASS. So we have the community-led health equity structural interventions, which we call CHESIs for short, the health equity research hubs, which we call the hubs, and the COMPASS Coordination Center. Next slide. So COMPASS is designed to be a 10-year program. Last year, we funded 25 CHESI awards and 1 award for the COMPASS Coordination Center. And beginning in July, we will announce the funding of up to 5 health equity research hubs. So we're really excited about that. So in the last few slides, I'll go over each of the 3 initiatives, reviewing the goals for each. Next slide. So the goal of the CHESIs is for community-based organizations and their research partners to develop and implement community-led health equity structural interventions that target social determinants of health. And this is in partnership with their local health equity research assemblies. Next slide. And wanted to highlight that informed by our listening sessions and in response to the theme to provide more support in navigating the NIH enterprise, we provided strategic community outreach and support for the CHESI applicants. We held 8 technical assistance webinars and office hours in which we had over 2,500 attendees. We held a technical assistance webinar to help prepare the full application applicants, where we had almost 800 attendees. And then we had 3 videos posted on our YouTube channel with over 3,300 views. So overall, we really wanted to be responsive to the applicant community based on what we heard in the listening sessions. Next slide. So this is a map of the CHESI awardees by HHS region, where you can see we have broad representation across the country. Next slide. And this map actually shows the community organizations that were awarded for the CHESIs, as well as the Coordination Center. And the Coordination Center was awarded to Drexel University. Again, you'll note the broad geographic distribution of the CHESI awardees. Next slide. So in terms of the social determinants of health and structural factors of each of the CHESI awardees, you'll note that each CHESI could have more than one focus area. We had 14 that focused on community health care and access and quality, 11 focused on neighborhood and built environment, 10 on the social and cultural context, 8 on economic development, and 6 that focused on nutrition and food environments. Next slide. And this slide just highlights the populations of focus. Again, each of the CHESI awards could focus on more than one health disparities population or racial and ethnic minority group. If you click here, you'll see that 5 of the awards focused on the children and adolescent population. And we had a broad racial and ethnic distribution for the focus areas as well. Next slide. So the CHESIs is broken down into a 3-phase process. So we are in the thick of year 1 for the planning of these structural interventions, as well as capacity and partnership building and the development of the local HERAs. Phase 2 is the actual implementation of these CHESIs in collaboration with the local HERAs. And then phase 3 focuses on assessing the health impacts of the interventions, as well as developing dissemination and sustainability plans for these interventions. Next slide. So just wanted to highlight the local HERAs, and I know there was a mention of like the task force in child obesity 180. The local HERAs can be considered comparable to that. Really key for community engagement and integrating diverse perspectives, really to help provide tailored and contextualized guidance and advice to the CHESIs, and really key for the sustainability of these CHESI projects once the funding is complete. And the whole idea of these local HERAs is for them to be comprised of a variety of different stakeholders. So from policymakers to nonprofit leaders, local foundations, and healthcare organizations, again, with the hope that it'll help with the sustainability of these CHESI projects. Next slide. So in the last two slides, I'll focus on the goals for each of the two remaining initiatives. So we have the 5 health equity research hubs, which will be again awarded in July. And the overall goal for these hubs will be to provide more tailored scientific support and interface with the coordination center to support local hands-on research training and capacity building, as well as ongoing research technical assistance, and to help provide quality assurance and risk management for the awards. Next slide, please. And the coordination center will act in parallel to the hubs, but will really be instrumental to leading the overall program management and coordination of the overall Compass program. It'll help with the assembling of the national HERA, and will really be key in initiating Compass research activities, helping with common research data and common data elements, creating the infrastructure for data sharing and management, and providing that support for the management across the various projects and hubs. Next slide. So the overall goal, again, of Compass is to help improve health overall, and by increasing our understanding of the mechanisms that produce and perpetuate health inequities and disparities, by helping to build a repository of evidence-based health equity research that could be used for future research opportunities, also to help provide capacity building and training curricular resources for other community-based organizations that are interested in engaging in research, and then lastly, to create innovative models to really accelerate the translation of discoveries into policy and practice. Next slide. So just to end, this is the timeline for Compass. Again, we are in the early phases of intervention planning and development. We're really excited for the research ahead. As you can see, we have a long road ahead of us, and really excited to see the health equity impacts for the program. So with that, really want to thank you for your time, and I look forward to the panel discussion.
Thank you so much, Alison. And I think we are now going to move forward with Denise. So thank you so much, Denise. Thanks for joining us.
Thank you. I am really glad to be here. Before I begin my talk, just a little tiny background about me. I am an associate professor here, but at the LSU Ag Center, I am also an extension specialist. So we work heavily in the field. And to that end, I implement, under my direction, we implement a lot of statewide programs, whether they're obesity interventions or food access. And so today, I am specifically talking about one of our programs, which is the Centers for Disease Control High Obesity Program in Louisiana. And we really have learned a lot of lessons from this project, because we started with the high obesity program almost 10 years ago today. Next slide. I do not have any disclosures to report. Next slide. Okay, so internally, our high obesity program is called Healthy Access, Behaviors, and Communities. Healthy ABCs. We like acronyms too, even at state agencies or local agencies as well. We've also call it Healthy Communities a little bit here as well. Next slide. So to give you a little bit background about the high obesity program at the Centers for Disease Control, is that it leverages cooperative extension services to increase access to healthier foods and safe and accessible places for physical activity in counties, or in our case, parishes, that have more than 40% of adults with obesity. So when we first applied, which was called 1416 at the time, we actually did not get funded until 2015. And at that time, we started with 4 parishes. Today, the funding is called 2313, and we now have 12 parishes. So we've grown, but one key aspect is that the original, 3 of the original ones, because a 4th one is no longer eligible, are still with us today. And the reason for that is, we've heard this time and time again, this work does not start or end with a grant cycle. And so the CDC had once told us we're in at least a 20-year relationship. And we took that to heart, because we really want to see if we give the rural communities and the decision makers the support they need, what changes can be made. So that's where we're at now. But what is really great about the high obesity program is that At the state office, our specialists, as well as myself, work cooperatively with subject matter experts, program officers at CDC. But then we also go work cooperatively with our agents who are positioned in these counties that you see on the map with the local residents. Those local agents work collaboratively with the communities, so it's a constant loop. You heard one of the speakers yesterday say that this is an iterative process, and it's a constant feedback communication loop that really needs to be had if these interventions that come into place are going to be sustainable over time. Next slide, please. So our overall impact from the last 5 years, and I will also reiterate what a speaker yesterday said, is this can be really slow work. You saw in the previous speakers that they have 1 to 2 years of planning. I think if you do it right, you have 1 to 2 years of planning to really do that formative evaluation, but then also to do a really good job on community engagement. So over the past 5 years, our team secured an additional almost $5 million in outside funding beyond CDC to support food system and physical activity enhancements in the parishes. So the team invested nearly $10 million in improving overall health in small rural communities with very high rates of obesity and very high rates of poverty. Over 30,000 people were impacted by improved access to healthier foods, which is about 40% of the population. Some of the interventions that were put into place, again, all of these were community driven, included cold or dry storage, establishing nutrition guidelines at food pantries, establishing local farmers markets. We've established a produce market, implementing healthy retail, supporting SNAP acceptance, and also healthy, market match programs as well. So nearly 25,000 people were impacted by plans, policies, or improvements to routes connecting everyday destinations, including parks, local businesses, schools, residential areas, churches, courthouses, and libraries. So this connectivity impacted 30% of the population. And what's really great and not reported here is our communities were able to draw down almost $13 million in federal funding from the Department of Transportation and the Transportation Alternative Plans to get sidewalks, crosswalks, ADA compliance, those type of things. And these small, less than 5,000 population places would not have been able to do this without this program and our ability to work hands-on with them in a nice, controlled pace, I guess you could say. Next slide. So how do we work with communities? And this is the really important piece. I'm a qualitative researcher primarily, and I've always gone in and done formative work, which is in large part qualitative, where you raise the voices of those who live in the community who are impacted. And so it always made sense to use more of a community participatory approach when we work with these communities. Our offices are stationed in Baton Rouge, and yes, we have local agents who work with them, but I cannot pretend to know that I understand fully what is going on in one of these parishes that we're targeting, which can be 4-5 hours away. So we very much work closely with the community residents, and we use coalitions and work groups. And so I know there were some other groups. It's kind of the same thing. Our team provides assessment and planning technical assistance, no cost. We also provide tools and guidance needed to empower these communities to be able to create the desired changes in an equitable fashion. And so one of the things that we're doing is we're almost teaching them to ride a bike. If they want to ride a bike, we support them. And for example, when I talked about the $13 million sidewalks, well, in engaging with them, we found out that they would never apply for that because the match rate was way too high. And it was hard for them to navigate this grants program. So we were able to work with the state agency, talk to them about why this was inequitable. They don't have the capacity for this match. They don't have the tax base. And so we were able to eliminate the entire match for certain populations of lower. And also we brought everyone in to get hands-on training about how to navigate the systems. What are the things that they're looking for? And that support, like I said, when you're riding the bike, empowered them to write these grants and draw down these funds. And I'll show you later, many of them have gone after other things. And so that's what I see our role is in this process. Next slide, please. So all of our programs, including high obesity, follow a very, very simple structure. They get to know their community. They host a community forum. They then build a coalition. They used pooled resources, either from the grant or from the community. And we support PSE changes within the strategy for that. Due to time limitations, I'm going to actually drop the published paper in here about this framework so that you can read in more detail. Next slide, please. So as we're navigating this framework with community input, community forums, again, we're using a community-based participatory research model for both the evaluation and the outreach part of this. So for those of you not familiar with community-based participatory research, it's an iterative process built on trusting relationships between community members and researchers. This includes feedback checks. Those are all the loops I'm talking about with community members and researchers throughout the duration of the project and even after. And we prioritize long-term commitment to sustainable change. So you see some of the community feedback we get when we collect data, we present it back. Does this make sense? Does this look right? Things like that. And then we may pivot depending on what that information says. Next slide. So in community-based participatory research, the communities are understood as distinct. And remember, they were saying the ingredients in one parish or county is not going to be the same as ingredients in another, what will work. So you work alongside the community members as outside researchers. This process is bolstered community support for project initiative and leads to more sustainability. And I'm actually going to show you that later on in the presentation. Next slide. In terms of community engagement using this approach, they participate in all aspects. They identify the barriers and aspects. These two young ladies right here are part of our youth coalitions, and they are actually doing the assessments for their park. The youth and adults below, this was called a Madison on the Crawl. And so while we had this big event where you could get your blood pressure checked and you can get access to these resources, we also wanted to get their voice in what they saw as the most dangerous area to cross to go to the grocery store or to go to the library. And so this simple dot voting gave us a lot of genuine feedback. And they're also involved in almost all aspects of the project, whether it's planning, development, implementation, and evaluation. We as the researchers know what works. It's our jobs to tweak that to fit the needs and desires of that community and those community members. Next slide. So this is the story I want to show you about why really great community engagement can lead to great things in sustainability. So this is one of our parishes that started with us in 2015. The big thing that came out of this is it's a food desert. We had a lot of farmers, but they were selling outside. They wanted a farmer's market. We started with literal trucks backing up to sell their foods. We eventually, as we got more input, we came together, we got a donated site, we did communication around it, got more feedback. Then we worked with the farmers to see why they weren't accepting SNAP or WIC. What was the barriers there? Once we found that out, we helped them navigate that process. Now they're accepting SNAP. Then they went after the state match SNAP program. They opened 2 different locations, one at the library, one at the the rural health clinic. At the same time, they saw a need for doing these farmers market box sales, highlighting of the vendors where you see with the Black History Month, a senior day, come partner with us to get those medical needs. So it's a very vibrant farmers market. It's wonderful. Then now we have the double up bucks, all of the managed care. They're sending us checks. That's what, an $8,000 check. It covered the SNAP match for the year, and we have more. We also now have a full-time farmers market manager. Then this is one of our vendors who actually went to the state legislator to support the authorization of this SNAP match program. And so just to see them get that voice that they always want. And here's where the sustainability comes in. Our agent left for a career move about 7 months ago. It's still going. It's still vibrant, it's still alive, and it's still better than ever. The farmers decided that we opened up a food pantry to the general public at schools. The fresh produce that's distributed at that food pantry comes from that farmer's market, whatever they don't sell. And so it's just to see them grow. They can do this. They always know the answers. They need some support. And so I guess that's my next slide, topic to you. If I say nothing else and I run out of time, authentic community engagement is critical for this work. We have a research plan. We may have a communication plan. You need a community engagement plan. And that's the take-home message. Next slide. All of you can see this. It basically summed up what I said. And also, you may want to partner with a local cheerleader, cooperative extension service, or a local nonprofit, whoever is powerful in that community, very trusted. Next slide. Thank you. If you'd like to learn more, I have the link here. We have all of our publications, and any of our resources are available to the public. Thank you.
Very, very exciting. Thank you so much for sharing that, Denise. And now we will turn it over to Kelli to share her wonderful work as well in Indigenous communities. Thank you, Kelli.
Thank you. Hi, everyone. Today I come as a Kickapoo, Seminole, and Muskogee Creek woman, an advocate for my community, a future ancestor, a daughter to the matriarch in this picture, and one of my favorite roles of auntie. I'm also a lifelong student in this work I've been privileged to be a part of. Today, I'm just going to give a 30,000 foot view of considerations for working in Native communities. Next slide. I have no disclosures to report. Next slide. Before we get started, I wanted to preface our conversation with the understanding that my comments related to Indigenous populations is directly referencing tribal nations in the United States. And I also want to acknowledge that I'll be sharing the art of Native artists, starting with this one by Star Hardridge, who's a Muskogee Creek artist. So I just wanted to also mention that. Next slide. We're pressed for time, so we're getting through this really quickly. I'd like to give a quick background on tribal nations for those who may not be familiar. There are currently 574 federally recognized tribes across 37 states, with over 250 tribes in Alaska alone. Aside from the tribes that are recognized by the federal government, there are a few dozen more that are state recognized and are not included in this number. So there's, closer to 600 tribes. And really, I encourage you to find out which tribes are located in your areas that you live or work, but also understand that those tribes may not have originated there due to their forced relocation. And the states bulleted here are those with the largest percentage of Native people in 2020, with Alaska being the highest, then Oklahoma, New Mexico, and going into the Northern Plains states. Next slide. The last census counted 9.7 million American Indian or Alaskan Native people, either alone or in combination with another race. Also, it's important to know that 7 out of 10 Native people live in urban areas. I think that's a surprising fact for some people. And, just related to that, many times our community members are living in both their family's home on their homelands or reservation, like maybe on the weekends, and then commuting during the week for work in a bigger city. And this is not uncommon, especially in the Southwest. Next slide. So when we talk about health systems that serve Native communities, we usually designate them into either IHS, tribal, or urban. We'll start with the Indian Health Service, or IHS, which you all probably have heard of, but it's the agency within the Department of Health and Human Services, and it's responsible for providing federal health services to American Indians and Alaska Natives in exchange for the land and oppression experienced by Native people. And the U.S. government made a trust and treaty obligation to provide certain rights, including health care. IHS services are administered through a system of 170 IHS and tribally managed service units. The second type is of health system are those that tribes operate, and the Indian Self-Determination and Education Assistance Act allows tribes the option of exercising their right to self-determination by assuming control and management of programs previously administered by the federal government. And the third health system is operated by urban Indian organizations, and it was established in 1976 to make healthcare services more accessible to urban natives. And there are just over 40 urban Indian health organizations that provide access to culturally appropriate and quality healthcare services. You might see some of these kinds of health systems in places like Denver, Albuquerque, Phoenix, Seattle, Oklahoma City. So they're in larger cities. And there are, like I said, about 40 of them. Next slide. So having kind of given the rundown and that background there, when you're working with these different types of health systems, there are different rules for working with these different types of health systems. So if you find yourself in this kind of situation, just know that they're all going to be different, and they all have different rules. So just because you did something at an IHS facility doesn't mean you can do the same exact thing or similar in a tribal ran facility. So that's one reason why I go over those things as well. Okay, so now that we have a little bit of context to tribal communities, let's dive into a quick overview of considerations when working in these communities. Next slide. So this is, I'm not sure if you can see that very well, but when comparing Indigenous versus Western lifeways, values, ethics, worldviews, and social norms, we see stark differences in how things are perceived or practiced. And this table is only showing just a few of these kinds of concepts, but they all seem to resonate with me personally, from things like community and working as a collective versus individualism, and knowing how important community is when working with Native people. And we've already heard from other presenters today how important community is, but it's especially important in our Native community. As well as the cooperative nature rather than competitive nature. And don't get me wrong, not that Native people can't be competitive, but the good of the whole is more important than the good of one. And relationships, relational is huge. Indian country is small, and the reputation that you have is a reflection of your family. It's a reflection of your community, and really a reflection of your ancestors. And there's a sense of responsibility that many Native people carry that's heavy. And so that's why relationships are so important within the community, and then also those relationships and who you're representing with people outside of your community. Next slide. So just kind of tying on to this more, working with our community is really centered around relationships, and taking the time to build trust and maintain a genuinely strong relationship is vital to the success of not only to a project or a policy, but really a people. And we rely on one another in community, going back to that collective concept. So when engaging with the tribal community, really invest in those champions in that community who others trust, and who can really be a source of success, really, when you're working in these communities. Next slide. It's not uncommon to find multi-generational households in our communities, not just a couple of generations in a household, but more like 3 or 4 generations in one home. Taking an intergenerational approach is also key. So wherever possible, include connections to ancestors or past generations, as well as future generations. Our elders and our children are the most important in our culture. They are our culture bearers and carriers, and is how we as a people have survived. Pictured here is my two grandmas. These are my great grandmothers who were a big part of my childhood. And you'll notice the can of beef on this image, which is meaningful, and it was a meaningful part of their lives, because they spit tobacco. And I'm bringing this up because this can of beef came from the government, came from government rations to tribal communities, which has undergone huge changes in the past few decades. There's still a long way to go, but I'm really hopeful when I see things like the Indigenous Animals Harvesting and Meat Processing Grant that was announced. I think most of us got an email today. And I find that hopeful as a start to support tribal food sovereignty efforts for our people and our communities, and getting away from the days of canned meat. Next slide. And I know we've said this before, but there's no one size fits all. The number of tribes and customs and traditions that exist are all very unique to that tribe or even that family or that clan. And adopting tribe-specific approaches based on a combination of traditional knowledge and best practice and evolving Native thought are appreciated. Next slide. The act of giving back and reciprocity in this work should be practiced, from citing elders and manuscripts to sharing results, good or bad. Again, closing that feedback loop with community, really should be high on the list. By practicing member checking to, again, build on the relationships and trust, and to make sure that you got it right by community, because again, it goes back to the relationships and how important that is, and that you are having this transparent line of communication and sharing. Next slide. In Indigenous spaces, a spiritual connection and lifeway are often acknowledged, and although the spiritual is generally avoided in Western academic practice, it really should be considered when doing this work with Native people. And this will look different depending on who you're working with. And so, again, just something to consider when you're working in these communities. Next slide. So just a quick rundown of really short best practices, inviting community input from the very beginning, and how you work with community. I can't stress that enough. Creating safe spaces for sharing and feedback, being mindful of the power dynamics that exist. And I will just say that I used to be a Fed. I used to work for IHS. I used to be in the Commission Corps, and I wore a uniform. When I showed up to Native communities, Native community spaces, they looked at me as IHS, as the government. They looked at me as not a community member, not a Native, not a dietitian. They looked at me as IHS, which was not always a good thing. And so I just really can't stress enough how important it is to be mindful of these kinds of power dynamics. I have that experience firsthand. And then also to trust communities know how best to serve their people. They've been doing this a long time. They may not do it the way you or I would want to do it, but again, trust that they know how best to serve their people. Next slide. And that's all I have. Thank you very much.
Thank you so much to our panelists. This was just an amazing discussion, and we really appreciate all of your time with these wonderful, fantastic overviews. So we have about a good solid, I think 18 minutes to have a good discussion. And so I know that your talks had to be concise, but they highlighted how you're working to authentically engage communities to maximize relevance and impact. So let's start with each of you sharing some of your most humbling experiences. I think you've alluded to it in your talks, but in doing this work, we learn a lot. So what have you learned in terms of humbling lessons, and what suggestions would you have for listeners as they work to better engage with existing communities and the work that they do and to forge stronger connections?
I'm happy to start us off. So
Sure,
speaking
Alison.
from the funder's perspective and kind of the I think it's important to understand the amount of time that it takes for community engagement and community-led work, and just to be realistic with timeframes. The good thing about the Compass program is that we're able to use what's called the Other Transaction Authority mechanism, and this is a unique mechanism that we use within NIH that allows for more flexibility and for us to be more nimble in our timeframes, other than our kind of traditional clinical trial mechanisms that we use. And what we're finding with the 25 CHESI awardees is that, time is needed to conduct the community assessment. It's needed to account for the timing to hire and, to really do the capacity building that's necessary for the varying levels of community organizations that we're funding for the CHESI awards. Also, the amount of time that it takes to really get community input, and input from the local organizations that are part of the local HERAs, in developing governing documents for the local HERAs, et cetera. So just being mindful, again, from the funder perspective of how much time it takes for authentic community engagement work. So.
Thank you. Kelli or Denise?
I will share the yes, time is one of those things, but I think a humbling lesson, and I know we don't have much time, or I could talk all day about how often I've been humbled working in community. I probably one of the most important things that come to mind is just in my own work and knowing how I should know things, being from this community. But, there have been times or a time when it only happened once, it only took once, that we were presenting on creating this curriculum for American Indians and Alaska Natives. And in the government and in other organizations, you pair AIAN all together. That's it, AIAN. Well, there was an Alaska Native person in the audience, and they said, this has nothing to do with Alaska Natives. Like, why are you even saying that it is? Because it's not. And that was a real true eye opener, and something that, I think others can learn from as well.
Thank you so much. And so I have, wait a minute, Denise, go right ahead. Were you gonna?
Yeah, I was just
Go
gonna
ahead.
share, I agree with all of them, but also, sometimes we go in there for childhood obesity work. But as we're engaging, we find out more. And what was really humbling to me is that as a dietitian, I'd say, eat your fruits and vegetables. What about these fresh fruits and vegetables? Drink 8 glasses of water. Almost the majority of the communities that we're working in for HOP don't have reliable drinking water. And so we're expecting them to move beyond that when they don't have some of the basic needs met. And so it's very humbling. And that's what cuts into their food dollar budgets. And so that it's just humbling, sad.
Thank you. And you guys are moving fast. I'm looking at the Q&A you're answering. You are on point, so I really appreciate it. So I have another question, and then I'm going to go to one of the audience questions. But Kelli, I loved in your presentation how you talked about the progress that we're making in terms of USDA promoting Indigenous food sovereignty, the work that the tribal nation is doing. And I appreciate you elevating the importance of adaptation across more than 500 tribal nations in this country. And I think we really have to acknowledge that there's a variability. And so I also loved hearing the other aspect that you talked about, generational knowledge, the spirituality. So can you and our other panelists expand on generational adaptations or other adaptations that you are making? Because there's such an important aspect of multi-generational approaches in the communities where you work. So I know that, so I'm just passing that off to everyone as well.
Yeah, I think trying to build a family approach. So that could look a million different ways. It doesn't necessarily mean programming for every generation offered at one time. It could be as simple as just understanding, okay, the grandparents are taking care of grandkids. Well, at the program that we're offering, can we provide childcare so that the grandparents can come or the parents can come and the kids can come, but still having that separate education component for the adults, and even having a separate education component for the kids, but just understanding that those are the real life situations that we're faced with in community, and that's across communities. So really kind of looking at how to address the whole family because they're sacrificing a lot just to be there.
Yes, yes, I think that's important. And I've been thinking about in just even in my life, being able to go to the gym, there's childcare. And so just simple things if we're asking people for their time to make sure that we're considering the family. So Denise, I'll ask you that question as well, or Allison, everybody's open up.
So in our communities, they're largely rural, except for Terrebonne that we just added, which is another learning curve there. But we see a greater population of older folks, and with that, those who are raising the children. And in some cases, in rural areas, they have a lot of social capital because that's where their families were born and raised. So it's just, again, really important. How does that change the way? I guess it didn't necessarily change the way, but we knew we needed to make sure we captured their voice. And so that's what kind of I was talking about with your community engagement plan. Who is in the community and who's not at the table, or whose voice haven't we heard from? Those underrepresented, reported. That's who we're going after.
Wonderful.
Yeah. And I'll add to that. So I know I didn't during my presentation didn't mention the Chezzies specifically, but there are two that focus on kind of family dynamics. So there's one in the Bronx in collaboration with an organization called Bronx Works is the lead with Montefiore Medical Center, and then an organization called Citizens Committee for Children of New York City. And they're looking at collaborating with residents in the New York City Housing Authority to develop and test the economic impacts of providing childcare access to residents. So again, thinking about the family, what that means for generational, wealth, or getting out of generational poverty, just, providing that resource for childcare and what that means for the well-being of the children, the families, and then also providing more kind of support through early care education as well and programming. So we're really excited again to see the findings for that, like focusing on the family dynamic. And then there's another funded program in Puerto Rico that's working to fight childhood poverty. Again, looking at the household dynamics and how that can have a trickle down effect to mental health. Services and care. So really, again, focusing on the family is really key, particularly for racial and ethnic groups that have that collective mindset, as Denise mentioned in her presentation, Kelli mentioned in her presentation, working with Indigenous communities. So certainly these intergenerational approaches are key.
Wonderful. Thank you so much, everyone. And so I'm going to take a moderator privilege and I'm going to sandwich some questions together so we can get it all in. And Denise, then I'm going to come to you because there's a specific question about your approaches. And so, Alison, I'm going to bring you into this question because we're both sitting at this federal level. And there's a question that says, how do you see community-led and engaged approaches driving and contributing to larger scale state and federal policy change? And I'll just say from my perspective, especially being a community-based participatory researcher in this role, that we must bring these skills into the work that we're doing at the state and the federal level. And so even though I'm going to pass it to Alison because Compass is all about that, right? That's how that came about, listening to communities. And so we are doing work, especially just one example, at USDA to really promote and make My Plate a household name. It is really one of the secretary's core priorities. So I'm actually on a My Plate promotional tour going around to communities, hearing about barriers, successes, and challenges because it is our federal symbol for healthy eating. And we want everyone to be able to use the resources. So we're making sure that it's contextually, linguistically, and culturally appropriate. And we're doing that work. And so this, you think about the work, Denise mentioned how she figured out what are the barriers to you enrolling people in SNAP, in WIC, and thinking about these community-based approaches and having boots on the ground to enroll and engage communities, because people from communities, as Kelli mentioned, want to hear from people in communities, not from people in our Brown Corps, Commission Corps, nothing against them, but they don't want to hear from people in uniform necessarily, right? And so, or from the federal people. So we have to really think about those approaches. But Alison, I want you to just kind of hop in there, and then I'll go to Denise on this next component of that community engaged approach.
Yeah. So while, policy is certainly a different lane that NIH falls into, but, the hope for Compass is that the evidence base and repository of evidence based interventions can help inform policy. And with any community engagement work, getting community members more involved, engaged in the civic process will hopefully in turn contribute to, even though, again, that's not the primary goal of Compass, contribute to kind of the political environment in which they live in and their local state communities to advocate for improved policies that really address the structural and social determinants of health that impact people's lives day in and day out.
Wonderful. And so again, as I commented on us prioritizing equity, and we have to hear community voices in order to prioritize equity and achieve nutrition security. So Denise, I'm going to come to you again. I'm sandwiching a question. There was an earlier question about how do we get communities to not necessarily be territorial or take ownership of these things and partnering together in this work. But you got a specific question on how did you determine what tools and guidance that your counties and coalitions needed, as well as did you deliver training to the agents and then pass them along to the coalitions, or did you provide training to the coalitions during monthly meetings? So I have another one, but I'm gonna stop right there because that's a lot. So if you need me to repeat, I will.
Yeah, so those are really good questions. So I will say communities can be territorial, and this is why I'm saying this. So in one of our smallest parishes or counties in the state, they have 3 distinct communities. The folks from Waterproof do not want to attend, don't care about the people in St. Joe, and they don't care about the people in Holston. So we had to then go into separate work groups. We focused on St. Helena as a whole, but when it came to like physical activity and some of those more granular level, that's what we had to separate out. So all that said, okay, so I'm gonna go back. What was great is that CDC had a whole list of evidence-based interventions. We know what that menu might look like. But Louisiana, if you've never been to Louisiana, we're a little bit different, as are maybe your communities in the Deep South. And so we knew that these needed to be tweaked for very hot summers, very humid, and then our pretty much year-long growing season. So how could we let it? So those, after we heard the different things that we were hearing from the formative evaluation, whether that was focus groups, interviews, community forums, data walks, crawls, as we called them. And then we came together and we were like, what are they saying? Match those up to the interventions. And then we go to them and say, this is something that you might want to consider. They're going to come up with first, usually why it won't work. And you acknowledge that, you put that to the side because it's something that's going to need to be addressed. But then let's talk about, well, what piece of this might sound like something you could do. So it's a very step-by-step process. But again, you take all the information you're hearing, whether it be from your agents, your specialists who are going out to do the evaluation, and you take that and you match it up to what you know works, or what the research is telling us what works in these areas. And then we have to tweak it and modify it for really rural, isolated areas. I think I might have answered that question. Okay, so for the agents, so once we started with the CDC and we saw the national, the cooperative extension framework, shifting to health and wellness. Extension has a focus on addressing the social determinants of health and disparities. In the middle of that, equity is at the core. So CDC was lining up with the national framework for health and wellness, and now it's, I'm sorry, I'm butchering the name. It just changed to health equity and well-being. So we were already starting to do that. So that's where we came up with the Healthy Communities Framework, to which all of our programs operate. They look different depending on what the funding guidelines are. But that in and of itself, once we built that model, in that article, I dropped a link to one of the moderators, so I think they'll share it. But that model became it for all, and helps us train our agents. We also made quick reference guides. We have a resource guide on how to do this. We have community forum scripts, which we're making new ones based on our experiences with communities, to really hone in on some of those unintended consequences of things. And so, yeah, so all of those are publicly available. I can provide the link to that. I'm sending it to you, Caree, like even how to do a walk audit. You want to go in and see what's happening. Can the kids really do a bike to school day? Probably not when they're up on a hill. It's dangerous. You can't see cars. And so we created these resources to share with others who are doing this work. But in terms of our agents, we've done a lot of trainings. And so we've made those resources available. I would encourage anyone to contact me because I have learned a lot from other groups doing this work. And I feel like we're going to do our best collectively when we learn from each other about what works and what doesn't. Did I answer?
Well, thank you. Yes, thank you, Denise. And again, you can reach out to Denise. She did just share a link, and so we'll get that to be sent. And so again, there are a lot of questions about overcoming stigma, partnership building in community. So I want to just pose this. We've got 2 minutes left. I'm gonna give everybody 30 seconds. And I want to hear, with the next generation of childhood obesity researchers and training them today, what are key strategies that come to mind for greatest potential, keeping in mind that our audience is asking about reducing stigma, the way that we speak, health lingo and health language, as well as partnership building in communities?
Yeah, so I can start us off. I think, with training the next generation, make sure you're training your mentees to be culturally humble, and culturally competent. With the Compass program, we really focus on listening first. I think that is really the key, starting with the needs of the community first. So with training, and training the next kind of cadre of childhood obesity researchers, really training them on qualitative methods, the importance of focus groups, the importance of key informant interviews to inform the work, and really working in partnership with community-based organizations that are doing the work, that know the community assets on the ground. But really, again, training around qualitative methods and having that stance of cultural competency and cultural humility, I think, is key with training the next generation.
Wonderful. Kelli and Denise.
Yeah, I'll just share that related to that that Alison just shared. I think what's effective is using a strengths-based narrative, especially in our communities. We know all the the bad things that have happened and that might exist, but I think the strength-based narrative, and then also asking community, related to key informant interviews, those kinds of things. Ask community what terms would be most resonating with them. So
Appropriate. Thank you, Kelli. And Denise, you get the last word.
Yeah, I was just exactly what Kelli said. So we found out very early on, you don't need to hear the word obesity. It's about having access to healthy foods and places to be physically active or play. That for our communities was a stigma. And also it didn't really mean much. They have enough going on to where, so what, I'm obese, maybe I'm categorized as overweight. And then we had our really outside superficial look like they're healthy, they're an ideal body weight, but they're not. And so we got rid of that because everyone can benefit from being physically active, having a place to play, and having access to healthy food. So everyone benefited. We took obesity out of it.
Well, thank you so much. This has been an outstanding, wonderful discussion. It warms my heart to see you, Alison and Kelli. Again, Denise, wonderful to meet you and learn about your work. Please, everyone, please join me in thanking our panelists today. Each of you, please keep up the great work that you're doing.